Right, sir? I'll try and finish in less. Okay, good afternoon, everyone. So, newer therapies in rosacea. When I started preparing this presentation, a thought crossed my mind. I thought, why don't we see topics like newer therapies in pyoderma, maybe, newer therapies in scabies, maybe, and newer therapies in chickenpox, maybe, in our conferences. And then I realized probably that's because we are happy with the way that we are treating our patients of pyoderma. And I thought we might not be very happy with the way we are treating a rosacea patient. So I thought I'll ask everyone, are you happy with the currently available treatment that you're recommending to you and to your rosacea patients? I'm going to go ahead and presume most of you are going to say no, right? And then I'm going to ask you why. Why are you not happy? We will go through first, review the currently available treatments and try to answer the why we are not happy. Before we move on to the treatment, it's important to realize that there are different aspects that we need to address in a rosacea patient. There's not just one symptom, there are many symptoms. And we have to address all of them individually and separately. So we have flushing, we have fixed erythema and telangiectasias, we have papules and pustules, and we have various types of phymas, rhinophyma being the most common one. Hence, it is very important to classify rosacea before you start making a treatment plan. Now let's move on to the flushing aspect of rosacea. Well, the mainstay of treatment is avoidance. This is what we recommend to our patient, and that's what they ask us. What is second best? I can't avoid. Avoidance, in my opinion, it's very hard for the patient to be compliant with avoidance. There are many common triggers of flushing in rosacea: sun exposure, emotional stress, weather, hot weather, wind, alcohol, etc., and etc. And it's difficult to avoid these kind of triggers for most of our patients. So what else can we do? Beyond avoidance, there are a few drugs which are available with us to manage flushing, including beta blockers and selective serotonin reuptake inhibitors, among others. However, the evidence supporting many of these therapies is very limited, and I will again presume that most of us are not happy with what we are offering our patients. Now coming to the traditional therapies of rosacea which are currently available with us. So we have the FDA-approved treatments, which include topical antibiotics, metronidazole being the only topical antibiotic being currently approved by the FDA in various concentrations and various formulations. Then we have the non-antibiotics, azelaic acid, which was recently approved by the FDA. And we have sodium sulfacetamide, alone and in combination with sulfur and various sunblocks. However, sodium sulfacetamide, unfortunately, is not available in our country. It's available as ophthalmic eye drops, but as a lotion or a cream to be used for us dermatologists, it is not available. So then we have non-FDA approved oral treatments of rosacea. There are certain standard treatments which many of us use. They include tetracycline, doxycycline, minocycline, etc. And there are other types useful but less commonly used oral antibiotics, including azithromycin, clarithromycin, even roxithromycin. Then there are oral antibiotics reported but not in common clinical use, including penicillin, erythromycin, omeprazole, and dapsone. And oral treatment of flushing other than beta blockers and SSRIs. And then non-antibiotic oral treatments, which include ivermectin, which is a relatively newer addition, and then isotretinoin, which we all commonly use, acitretin, ketoconazole, spironolactone, and prednisolone, only for rosacea fulminans though. Then we come to the non-FDA approved topical treatment of rosacea, which is currently available with us. Various antibiotics, clindamycin, erythromycin, benzoyl peroxide, etc. And then we have topical treatments which are reportedly used effectively, which include azelaic acid in a different concentration though, as compared to the one which is FDA approved, permethrin, adapalene, tacrolimus, pimecrolimus, and oxymetazoline. Then others which are theoretically useful but not, we have not experienced a lot of benefit with such treatments. They include cotameton, lindane, benzoyl peroxide, retinaldehyde, etc. Then come the physical therapies that are commonly used currently, which include long pulse NDR laser, IPL, and pulse style laser. So what is the problem with all these treatments? Who's going to answer me that why are we not happy with all these treatments? Okay, I'll answer it myself then. Why we are not happy is because all these treatments only address the symptoms of the disease. Right now, we don't even have a single disease-modifying agent available with us for rosacea. And that is the reason of unhappiness of all our patients and, the treating doctors. Now let's move to what's new. What has come up over the last 3, 4, 5 years in the management of rosacea. So this is what's new. In topical treatments, We have now ivermectin, we have brimonidine, we have tranexamic acid, we have dapsone. In oral treatment, we have low-dose doxycycline, and physical therapies, fractional radiofrequency. Let's try and find out how beneficial these treatments are. Starting with topical ivermectin. Ivermectin is a macrocyclic lactone with broad-spectrum activity against multiple parasitic organisms, including onchocerciasis, strongyloidiasis, pediculosis, scabies. So how it works in rosacea? Most likely owing to its activity against the Demodex mite, which theoretically has a role to play in the pathogenesis of rosacea. Along with having a antiparasitic activity, it also has anti-inflammatory effects, which are probably achieved through decreasing neutrophil phagocytosis and chemotaxis, inhibiting inflammatory cytokines such as interleukin-1 beta and TNF-alpha, and upregulating the anti-inflammatory cytokine IL-10. So this is the possible mechanism of action of topical ivermectin by which it works in rosacea. Now, clinical studies. Right now, it is now reasonably well-studied molecule in the treatment of rosacea. These two studies are really big studies, having more than 600 patients and conducted at different centers. The first one is a study comparing topical ivermectin to placebo or a vehicle cream, and it showed after investigator global assessment showed significant improvement in the inflammatory symptoms of rosacea as compared to a vehicle cream. And the second was a comparative study to azelaic acid. Again, it was found to be more effective than topical azelaic acid in the management of inflammatory lesions of rosacea. These are the studies of oral ivermectin, and oral ivermectin is also found to be quite useful in managing the symptoms of rosacea. So what are the salient features of topical ivermectin? It was FDA approved by the FDA for the management of inflammatory lesion of rosacea. Once daily treatment is recommended. It was approved in 2014 in December. It's available as Ivrea cream by Ajanta Pharma in India. It has a very low side effect profile, quite safe to use. The long-term safety studies are also available with us. And in another study, it was compared to topical metronidazole, and it was found to be more effective, with more improved quality of life, reduced lesion count, and more favorable participant and physician assessment of disease severity. So when to prescribe? Primarily in papulopustular rosacea. It hardly has any effect in reducing the erythema associated with rosacea. That's why I initially mentioned it's important to classify rosacea before making a treatment plan. Now, coming to topical brimonidine. So what is it? It's a highly selective alpha-2 adrenergic receptor agonist. It acts by its vasoconstrictive action on human subcutaneous vessels with a diameter of less than 200 micrometer. It helps in reducing the erythema associated with rosacea and is not intended to eradicate papules, pustules, or the phymatous changes associated with rosacea. It's a very fast-acting drug and almost has leads to an instantaneous reduction in the erythema. It's available in India's Erythego gel by Acumentis Pharma. Although I've been just informed by the Galderma representatives that they're planning to launch the original brimonidine topical by September or October of this year. So how to apply? The application advice, which is important to minimize the side effects associated with drug, is initially it's to be applied only once in a day in a very small quantity, and it's important to spread it evenly all over the face. Now, if you don't do that, it leads to a patchy appearance or a streaky appearance because it acts on some areas, doesn't act on the other areas. And this once daily application can eventually and gradually be increased to 3 to 4 times every day. So adverse effects associated with brimonidine. They're maximum in the first month of application, and it's commonly associated with worsening of erythema, burning, stinging, and itching. There are no long-term adverse effects seen over a period of 12 months in a study. However, 12 months, I don't think it's a long enough interval for us to really comment on that it's a safe drug to be used on long-term basis. The limitation is that it's only a temporary improvement in erythema, and there's a very strong rebound after stopping the treatment. And this is a picture to show you how fast it acts and how fast the erythema comes back. So same patient, after single application of topical brimonidine, after 30 minutes, there is a grade 2 improvement in the appearance of the erythema. After 3 hours, it is still maintained. And from 6 hours onwards, the effect starts to reduce, although it is maintained up to some extent till 12 hours after only a single application of brimonidine. So when to prescribe? Primarily erythematotelangiectatic rosacea, and primarily for patients who are looking for an instant relief, not really looking for a long-term treatment alternative. To give them that feeling of well-being, maybe to attend a party or a function or something. Now, topical tranexamic acid. It is not well investigated in rosacea. The level of evidence is very, very, very poor in rosacea. All I could find was 2 studies. One of the study mentioned that topical tranexamic acid could improve the epidermal, not definitely does, could improve the epidermal permeability barrier function and clinical signs of rosacea, likely resulting from the inhibition of PAR2 activation and consequent calcium influx. So I'm not really convinced by the evidence that I could look up on the regarding topical tranexamic acid. And ideally, right now, I don't think it has a role in the current management strategy of rosacea, but invariably it happens that we have exhausted all our resources, we have tried all the medications, only then maybe topical tranexamic acid can be considered in desperation in patients of rosacea when nothing else is working.
Please finish.
Right, sir. So topical dapsone, comparable to metronidazole gel, sub-antimicrobial dose doxycycline. The only catch here I'll tell you is that the mechanism of action of 40 milligrams of doxycycline is anti-inflammatory and not antimicrobial. The rationale of reducing the dose is to minimize the side effects and to minimize the development of resistance. I think, and everybody I feel would agree that doxycycline anyways doesn't lead to a lot of side effects, and if side effects is the only concern, then I don't think we should use the substandard dose. I think we should continue if there is scope of more improvement with 100 milligram doxycycline as compared to 40. Lastly, fractional radiofrequency, mechanism of action unknown, again only 2 studies, may or may not lead to reduction in the symptoms of rosacea. So now, where do we stand? This is what has come up in the last 3-4 years. Has it really changed what is, what we target in the management of rosacea? Well, topical ivermectin is a safe and viable addition for inflammatory lesion of rosacea. Topical brimonidine, rescue drug maybe, that's my opinion. And I feel that it has got a lot of potential for abuse by patients. You give a patient of rosacea a cream to apply which will take care of the erythema in half an hour. I feel it has a lot of potential for abuse. If I extrapolate from ENT, a similar drug, oxymetazoline, on long-term usage has led to atrophic rhinitis. Now, we don't know what kind of effects brimonidine is going to have on skin if it is abused for a very long period of time. So I would be a little wary of this drug right now, although it's a good rescue drug. So lastly, we are still no closer to finding a DMD for rosacea, and we are still treating the symptoms. And that is all. Thank you very much, everyone.
Thank you, Pikun. You have left no time for the questions, so we'll straight go to the next speaker.
I invite Dr. Sumit Gupta to give a talk on periorbital hyperpigmentation.
Thank you, everyone. At the outset, I would like to thank Dr. Rishi, our President, and Scientific Chairperson, Dr. Kandhari, to give me this opportunity to talk about dark circles. Dark circles. Eyes are portals of non-verbal communication, but when dark circles are present around them, they only convey negative emotions, negative state of mind, and overall bad health. So this condition has a lot of synonyms. Every new paper, they try to coin something more intelligent, and in effect what it does is it increases the keywords for people like us who are trying to prepare a talk to search on the PubMed. So there are barriers for collecting good epidemiological information for this condition, because it is considered physiological by many physicians also and many patients also. It is just a cosmetic nuisance. Also, many people have just transitory dark circles, although we do know that some patients have a very bad quality of life because of them. However, there was a study by Seth et al. From Gujarat. It was a hospital-based study which studied the prevalence and common causative factors of this condition, and it found that prevalence of this condition is 30.76%, and most common age group it affects is 16 to 25 years, and a very high preponderance of females to the tune of 4.2:1 was found over males. Etiology, as most things in dermatology, is multifactorial. However, the things which are displayed to the left are more important, and this list is an exhaustive list. Most of these etiological factors work by these mechanisms, which are hyperpigmentation of skin, vascular mechanisms, bags, and hollows. Most patients have a combination of these mechanisms working together. So coming to the first mechanism, hyperpigmentation of skin. So it can be post-inflammatory, secondary to any eczema, seborrheic or atopic. Genetic is the most common cause of hyperpigmentation of skin, as that study which I quoted earlier found out, and it has an autosomal dominant inheritance. Nevus of Ota, it is dermal melanocytosis because of improper migration of melanocytes from dermis to epidermis. Acanthosis nigricans, pigmentary demarcation line, and sun exposure, and certain drugs like minocycline, as well as hormonal factors, especially progesterone has been found to be a major contributing factor to this hyperpigmentation, and it has been found that women around menstrual cycles have more pronounced hyperpigmentation. So these are few examples. On the left, we can see a patient with acanthosis nigricans of the periorbital skin. On the right, we can see a post-inflammatory hyperpigmentation secondary to seborrheic dermatitis, and on the bottom, we can see a nevus of Ota. So as I said, genetic is the most common cause of hyperpigmentation around eyes, as found by that study, and it is morphologically described as a curved band of brownish to black pigmentation on the skin of the lower eyelids with velvety to coarse texture, with frequent involvement of upper eyelids. So more often than not, it's a circumocular pigmentation than just an under eye pigmentation. A group from Bengal, Dr. Malakar, found that most patients in his OPD had periorbital hyperpigmentation, which is an extension of the Fuchs line, or the pigmentary demarcation line F, and they thought it is also probably the same thing as the genetic hyperpigmentation. So we normally do this to all our patients who present to us with periorbital hyperpigmentation. So stretching of lower lid does not cause significantly lightening of dark circles caused by this particular mechanism. Okay. So coming to vascular mechanisms, which are vessel dilatation, deoxyhemoglobin, that is decreased oxygen saturation of the blood present in that area, and extravasation of RBCs, which in turn lead to hemosiderin deposition. So all these three mechanisms have been established in different studies. So there have been a lot of studies measuring oxygen saturation, difference between the periorbital region and the cheek, and they found significant difference in the oxygen saturation of people who have dark circles. And many histopathological studies have also found hemosiderin deposits, so it is extravasation which is taking place. Another factor, congestion of nasal and paranasal sinuses, lead to all these three vascular